Alright, so let's get started from where I left. And I was talking about the acute inflammation. And the last thing I said that if the acute inflammation is short-lived, it means that it is resolving in hours or to a few days, then it is, of course, acute inflammation. But if it is taking more time than that, then it becomes chronic inflammation. Now, so we have mastered acute inflammation in our previous part, and it's time to talk about what actually happens when the inflammation does not resolve quickly. This is we are taught now. This when this happens, we actually enters in the land of chronic inflammation, and you have to think of it as a prolonged battlefield in your tissues. So, unlike acute inflammation, which is dominated by neutrophils, chronic inflammation is dominated by macrophages, lymphocytes, plasma cell. So macrophages basically they clean up the crew and they are cleanup crews and commanders, and lymphocytes are they simply coordinate the immune attack, and plasma cells produce antibodies for ongoing defense. So they are simply long-term fighters. And unlike acute inflammation, chronic inflammation shows a mixture of destruction and repair. So the tissue is constantly being attacked and rebuilt, which can lead to scarring and functional loss. So this is what actually happened in the chronic inflammation. Now from here I can link something which is called as chronic granulomatous disease (CGD). So before we jump into granulomas, let's talk about a classic immune deficiency. Chronic granulomatous disease is caused by a defect in an enzyme which is called as NADPH oxidase. So this enzyme is needed by neutrophils and macrophages to produce reactive oxygen species for killing pathogens. Without it, patients are prone to recurrent uh, catalase positive infections. So diagnosis is done by NBT test, nitroblue tetrazolium test, which is abnormal, and uh, the test, which is also abnormal in the case of CGD. So there is a very different pathology for the CGD, but I think I should keep this in the track and tell you what CGD is, because examiner mostly focus on the defect in the NADPH oxidase. So, in CGD, the body keeps forming granulomas because it cannot fully clear the infection. That's why I talked about CGD here. Now, if I talk about the granuloma formation and how it happens, so a granuloma is basically a structured attempt to wall off something the body cannot destroy. So the stepwise mechanism is that antigen-presenting cells like macrophages encounter a persistent pathogen, and then they release IL-2, which drive Th1 differentiation. Th1 release interferon gamma, activating more macrophages. Activated more macrophages then transform into epithelioid histiocytes and fuse into giant cell. So in simple, that APC macrophages uh, release IL-2, and IL-2 stimulate Th1 differentiation. The Th1 then release interferon gamma and macrophage, and this they causes macrophage activation. Now these activated macrophages are simply called as epithelioid histiocytes and giant cells. So granulomas are organized army of macrophages, sometimes fuse into giant cell surrounding a center that may or may not have necrosis. So now, if we talk about the granuloma type, so it is basically divided into two types, whether it is having central necrosis or not. The first type is caseating granulomas, in which the central necrosis is present, and actually the caseating means cheese-like center. So they have central necrosis present. Classic causes of the case-eating granulomas is tuberculosis, fungal infections, and histology. Upon histology, you will see the epithelioid macrophages plus Langerhans giant cells having horseshoe nuclei. Now, the non-caseating granulomas, they are not having any central necrosis, and the classic causes are sarcoidosis, Crohn's disease, berylliosis, And cat scratch disease, primary biliary cholangitis, if I'm not mistaken. And histology often shows foreign body giant cells with haphazard nuclei. So that is, yeah, that's it from my side for the chronic inflammation. Now, there is a mnemonic for that, that's SARC B cause. So from SARC we mean sarcoidosis, from B we mean variolosis, and CA, from CA we means cat scratch, and C means Crohn's disease. SARC because C. Anyways, so this is from the chronic for the chronic inflammation. Now there are quick tips for exam that keep in mind that Langerhans giant cells uh, are simply they have horseshoe nuclei and they are typically crescent in granulomas. Foreign body giant cells in the non-case eating granulomas, they have nuclei scattered randomly, and it is a typical presentation of the non-case eating granulomas that they have scattered nuclei. So, another important thing that chronic inflammation is both destructive and repetitive and reparative, and the end result is fibrosis. Now, think of acute inflammation as a quick skirmish. Neutrophils rush in, fight, and either succeed or die off. Chronic inflammation is a long siege. Macrophages, lymphocytes, and plasma cells linger, fight, and try to wall off the enemy. Sometimes they form granulomas to contain what they cannot eliminate. So that's it from my side from the chronic inflammation. Now, moving on towards the next topic, which is wound healing and repair. So we have discussed acute inflammation and chronic inflammation. Now it's time to see that how body repairs itself. This is wound healing and tissue repair. Essentially, uh, uh, the body cleaning up the battlefield and rebuilding the tissues. So think of it like constructing a building after a storm. Scaffolding first, then strong walls, and finally finishing the touches. So there's first thing that you should know about the collagen switch. So one key concept in the wound healing is the collagen switch, because let's suppose there is granulation tissue. Early repair granulation tissue is pliable and it is made up of type 3 collagen, right? So let's suppose there is a chronic inflammation and then now the tissue is going to repair. Now this early repair tissue, this early repair plaster is made up of the type 3 collagen, right? And it is pliable. Now later on, the late repair, it will be turned into the type 1 collagen, and it is a scar tissue, it is strong, and that's it. Yeah. So this transformation is mediated by some enzymes called as collagenases, which requires zinc as a coordinator. So if the patient is zinc as a cofactor. So if the patient is deficient in zinc, then he or she cannot convert the type 3 into type 1, and it would lead to the lack of scar formation. So this transformation, yeah, I told you that this is mediated by zinc and collagenases, yeah. So remember one thing, that type 3 is early, weak, and flexible, and type 1 is a strong, mature scar. Now, there is something that I want you to differentiate between keloid and scar. So in keloid, you are having, so first of all, let's talk about what is keloid is. So people often confuse keloid and hypertrophic scar. You can say that in simple terms that keloid is somewhat, you can say that it is disorganized scar formation, right? And now the keloid and hypertrophic scar actually resembles a lot, because keloid got similar background as the hypertrophic scar. So collagen in the keloid, the type 3 collagen is more present. The type 3 collagen is not being converted into type 1 properly, and the patient is having type 3 collagen more. So if the patient is having more type 3 collagen, so you can say that it is type 3 collagen is pliable, and that's give a pliable appearance. Whereas in the hypertrophic scar, a complete scar is formed, and it is having the type 1 collagen more, and that's why it is not as pliable as keloid is. Now, the extent of this is that keloid is spread beyond the borders, right? And the hypertrophic scar is confined to the borders. This is a very important point that you should keep at the back of your mind. Now, the outcome is that keloid recurs frequently. Even if you resect it, then there's a high chance that it may reoccur. But the hypertrophic scar undergoes a spontaneous regression. Sorry. So if the scar is huge, climbing beyond the wound, think keloid. If it is thick but stays within the border, think hypertrophic scar. Now, there are few key growth factors that I think that you should remember, that there is something called as TGF beta that drives the fibrosis. There is something called as vascular endogenesis growth factor, vascular endothelium growth factor, VEGF, and it drives angiogenesis, formation of new blood vessels. And there is something called as platelet driven growth factor, PDGF, and it promotes smooth muscle and fibroblast migration. And there is something called as FGF, and it also promotes angiogenesis and tissue proliferation. So think of these as the construction crew and architects of the wound repair. Now, there are 4 phases of healing, and wound healing, it progresses through 4 sequential phases. So the first one I'm going to talk about is hemostasis. So hemostasis is first of all the immediate process, and it starts right after the injury. Platelet aggregate and form a fibrin clot, and you just think that body plugs the leak and lays down the initial scaffold. The other phase of the healing is the inflammation, and it takes 1 to 3 days. So neutrophils arrive and they clean up the bacteria and debris. Then macrophages arrive within 48 to 96 hours. Then there is deep debridement, and they secrete growth factors, CGF beta. And this is the cleanup crew plus the signaling team. And without proper inflammation, repair cannot proceed efficiently. Right now, this is the same story that I have told you back in chronic and acute inflammation. So you see that neutrophils are first arriving because it is acute inflammation. Later on, the macrophages surge because after 24 hours you are entering simply into the ground of chronic inflammation. So yeah, that's it. Now, the third phase is proliferation, and in which the granulation tissue forms, fibroblasts plus new blood vessels form, and there is angiogenesis, which is driven by the growth factors, especially VEGF, and there is collagen 3 deposition by the fibroblasts, early scaffolding, there is wound contraction by myofibroblasts, they pull the edges together, and imagine scaffolds being built, roads laid, and walls starting to form. So the fourth phase is the remodeling, and in this phase the type 3 collagen is replaced by the type 1 collagen, stronger and mature scar. Tensile strength increases from 10% immediately to the 80% over the 3 months, and this is the finishing touch and of the construction, making the tissue as strong as possible. So a quick mental picture I would give you: that hemostasis, plug the hole; inflammation, clean up crew; proliferation, scaffolds, new vessels, collagen 3; and remodeling, replace the scaffold with strong walls, type 1 collagen, maximize the tensile growth. Now, this is all about the wound healing. I hope you understand this, and I try to do something like a commentary style, and this is what I can do for you. So if there's any difficulty, then of course you can contact us on our Instagram page or on our forum WhatsApp group, wherever you feel comfortable. Now, let's talk about the hemodynamics and the edema and the fluid. So now we know how the tissue responds to injury and repair. So we should talk about how fluid moves in and out of the tissues and what happens when this balance goes wrong. So this is edema and fluid dynamics, a very high yield topic for exams and clinical practice. So on the first thing to know about the edema is the type of fluid accumulating. So either it is transudate or either it is exudate. So low protein. So let's talk about the transudate first. So it is having low protein. It is a clear fluid. Low protein means less than 3 grams per dl. So think pipes, leaking walls are intact, And the common causes of transudate is the heart failure, increase in hydrostatic pressure, the cirrhosis, decrease in plasma protein, and nephrotic syndrome in which the plasma proteins leak out of the body through the urine. So transudate actually happens when you are having low protein. When you are having low protein, keep this in mind. And The walls are normal. The walls are completely fine, but the law walls are leaking something. Walls are leaking the fluid, right? So keep this in mind that again, I'm saying this again and again that transudate fluid actually simply means that you are having low protein into the fluid. I'm not talking about the blood right now. Of course, it also happens in the blood if the body is having deficient in protein, but the quality of transudate protein is the quality of transudate fluid is that the transudate fluid is also itself having low protein, right? So I'm summarizing the stuff. So what is transudate fluid? Transudate fluid simply means that you're having sometimes, almost 90% of the times, you're having low protein in your body, and this low protein simply decreases the oncotic pressure, and as a result of this you are having leaky vessels rather than the damaged vessels. You are just having leaky vessels, and the vessels leak out their fluid into the tissues, right? And now if you sample that fluid that is just leaked out into the tissues, so if you see the content of that, then you will see that that fluid is having low protein, less than 3 gram per gl, right? So this is the picture of the transudate fluid. It actually happens when the body is having less no protein, right? As in nephrotic syndrome, when your body leaks out the protein. As in cirrhosis, your body cannot produce the albumin. And if the patient has been having heart failure, when the fluid pressure is too high, and it can also happen in the these are the common examples. So now, in contrast to transudate, if I talk about the exudate fluid, then it is having high protein, cloudy fluid. Walls are actually leaking. Walls are defected, right? And the common causes include infection and malignancy. Keep in mind that malignancy is one of the most common cause of the exudate fluid. uh, you know that USMLEs always they are so fanatical about the most common cause, most common scenario, this kind of stuff. So exam trick is that if the fluid is protein rich, cloudy, think of inflammation or infection, and it would be the exudate. If it is clear and low protein, think systemic causes like the heart failure, liver disease, or kidney disease, like the transudate fluid. Now, there are something called the Starling flow forces, and they are actually the fluid tug-of-war. So, a fluid movement across the capillaries depends on the tube pressure. The hydrostatic pressure pushes the fluid out of the capillaries, and the oncotic pressure pulls the fluid into the capillaries. So, edema occurs when the hydrostatic pressure is more than the oncotic pressure. So hydrostatic pressure is high, it pushes too much the fluid out. Example in heart failure. Again, if the oncotic pressure is too low as compared to the hydrostatic pressure, as in the liver failure or nephrotic syndrome, so the vessels are not good enough to pull this fluid back, and they leak this fluid into the tissues, and again this causes the edema. So think of it as a tug of war between the pushing forces and the pulling forces in your vessels. And the pushing force is hydrostatic forces, and the pulling force is the oncotic pressure. That's it. Now, there is something called as anasarca, and this is the extreme case when the edema is severe and generalized, involving subcutaneous tissue all over the body, and it is called as anasarca. So the classic causes include severe nephrotic syndrome, severe liver failure, and that's it. So you just keep in mind that picture a patient in your mind with a generalized swelling from head to toe. That's anasarca. Pulmonary edema. So if I talk about the pulmonary edema and the types, so first of all, pulmonary edema is the fluid in lungs, and it can be life-threatening, and comes in two flavors. So the first of all is cardiogenic and the non-cardiogenic. So cardiogenic, it is caused by the left heart failure, and that increase in the hydrostatic pressure in the pulmonary veins. Pulmonary capillary wedge pressure increases, and the fluid backs up into the alveoli, and this causes dyspnea and orthopnea. And if I talk about the non-cardiogenic edema, it is caused by the alveolar injury, and which increases increased in the permeability, which causes increase in the permeability of vessels. The pulmonary capillary wedge pressure, PCWP, is normal here, and it is seen in sepsis, trauma, and inhalation injury. Now let's talk about the lymphedema. So lymphedema is a protein-rich fluid accumulation. It is caused by the disruption of lymphatic drainage. Fluid is protein-rich, unlike most transurate, and the classic causes of the lymphedema is the radical mastectomy, lymph node removal, and filariasis, which is caused by a parasite called as Wucheria bancrofti, and which is a tropical parasite. Now, there are some clinical pictures I want to share with you, which is the pitting edema versus non-pitting edema. So pitting edema is simply you press your finger, indentation remains, so it is a pitting edema. And it is usually caused by the fluid overload like heart failure and cirrhosis and saltwater retention. In such cases, we usually give Lasix, also known as furosemide, 20 mg or 10 mg. Now, the non-pitting edema, in the non-pitting edema, you press your finger, there is no indentation, so it is usually protein-rich or the infiltrative edema, and it is usually caused by the mixed edema, which is caused in the hyperthyroidism and the lymphedema. So that's it from my side. So just giving you a quick mental image is that the transudate, pipes leak but valves are intact. Exudate, valves themselves are leaking. Lymphedema, drainage system is blocked. Pulmonary edema, lungs flooded, and it is of two types, cardiogenic and non-cardiogenic. In anasarca, the whole town is flooded. Now we have understood the dynamics, the edema and the fluid dynamics. So we should talk about the opposite problems when the blood clot inappropriately inside the vessels, also known as thrombosis. So you can see that how I arranged the topic, because I always wanted to link the topics, and I also wanted to create some type of opposition or between the topics and contrast between the topics. Anyways, so the thrombosis is not just a lab phenomenon, and it can cause heart attacks, it can cause strokes, pulmonary embolism, so it is a very highly clinical topic. So first of all, let's talk about the Burkitt triad, and first of all, I'll talk about the endothelial injury. So it is caused by the damage to the vessel lining, and classic example include the so first of all, endothelial injury is actually the damage to the vessel lining, and the classic examples are atherosclerosis, vasculitis, homocysteine toxicity. And the key for the arterial thrombi is that arteries deal with high pressure flow, so endothelial integrity is critical, right? Now that's it. Yeah. So the second thing, which in the Burkitt triad, is the abnormal blood flow. So these are three factors that may contribute to thrombosis. The first one is endothelial injury, right? So again, I told you that endothelial injury is simply damage to the blood vessel lining, and if there is any damage to the endothelium, you are simply inviting the thrombus to form, because endothelium is usually antiplatelet. But if the endothelium is injured, then there is nothing antiplatelet in your vessels, and this is an invitation to the thrombus formation. Now the second thing is the abnormal blood flow, and it is caused by the stasis or turbulence in the blood flow. So stasis actually happen in someone who is immobile patient, and this leads to DVT, deep vein thrombosis. And turbulence actually happen if someone is having atrial fibrillation, and the blood pools and form the clot. So let's suppose if you are having a heart and your atria is in fibrillation. So when the atria is in fibrillation, it is not contracting normally, right? And actually the current is too high during atrial fibrillation that the atria is not even contracting, right? It is trying to contract, but it is just jerking, not contracting. So in such cases, the blood is pooled into the atria, and when the blood is pooled somewhere, when the blood is static somewhere or pooled somewhere, so it is a very great environment trust me, it is a very great environment to form the clots. And that's why patients who are actually having atrial fibrillation, we calculate something called the Shad's-Wax score. If the Shad's-Wax score is high, above the 3 or 4, if the patient is having a score of above 4 or something like that, so we put those patients on the anticoagulation, like the apixaban, which is an anticoagulant, like clopidogrel or something like that. So we put those patients on the anticoagulations, right? So the other thing that might contribute to the clot formation is the hypercoagulability, in which the blood is too sticky, so it might be caused by the factor 5 Leadin, which is actually the anticoagulant. But if it's defected, then again you are having high chances to get to have the hypercoagulable blood, protein CNS deficiency, and that's it. It can be acquired through cancers, pregnancy, estrogen therapy, OCPs, and that's it. So it is also a key for the DVT and pulmonary embolism. So that's it. Now, if I talk about the two different things, which is arterial versus venous thrombi, so uh, it is first of all very critical to differentiate between to distinguish between the arterial and venous thrombi, because their composition and treatment differ. So arterial thrombi is platelet rich. It is a white thrombus. It is having lines of ZAN, ZAH and ZAN, and they are alternating pale platelets and darker fibrins seen ante-mortem. They are not seen, of course you can see these things ante-mortem and during post-mortem of the patient. The typical sites of the arterial thrombi is the coronary sites and the cranial cerebral arteries, and the treatment is as antiplatelets like the aspirin. Now this is something I used to confuse when I was a student, because when to give aspirin and when to give heparin. Keep this in mind. Now, if I talk about the venous thrombi is RBC rich and fibrin rich. It is a red thrombus, right? And typically it happens in the DVT due to stasis in the veins, and treatment is anticoagulations and anticoagulants like the heparin. Now, the risk factor checklist there are something called as DVT risk factor checklist, things that can lead to the DVT, and there is a checklist for that if the patient is immobile or post-operative or post-op, I mean it simply means that the patient has just come from the operation, and if someone has come after operations, of course he is immobile and resting on the bed for a few days. So if the patient is immobile and post-op, the patient is having stasis in the veins. If the patient is pregnant and she is using OCPs, oral contraceptives, so estrogen is present in them, then it is, and pregnancy is also a high estrogenic state, and of course it is also a risk factor for the hypercoagulability. Malignancy can lead to hypercoagulability, and you can see the Trousseau sign, migratory thrombophlebitis, which actually happens in the pancreatic cancer. Keep in mind that malignancy is a hypercoagulable state, and that's it for you. Factor 5 Leadin genetic defect in the factor 5, and it also leads to the genetic hypercoagulability. So think like a stasis, sticky blood, vessel wall problem, anything like that, it will lead to the DVT. So there is something called as disseminated intravascular coagulation, and it is actually the chaos. So DIC is basically a widespread microthrombi formation which consumes the platelets and clotting factors. The paradox is that the patient clots and bleeds at the same time. So lab features include the increased PT and PTT, and the clotting factors are used up in this case. Keep in mind that it is a state in which you are using clotting factors. It is a state in which you are using a lot of platelets, right? You are producing a lot of clots, that you are using clots, and then that you are using clotting factors, and that you are using platelets, right? So keep this in mind. If you keep this thing in mind, that you are producing clots, more clots, and clots to such extent that you are using the clotting factors, you are making your body overwhelmed, so you will get a concept of DIC. Now, the lab features include that if the patient is having deficient in clotting factors, and of course PT and PTT will increase, platelet count will decrease, fibrinogen will decrease, and because you are using a lot of fibrinogen to make the clots, and D-dimer, it is the best test to distinguish if the patient is having DIC or not, so the D-dimer will be increased. So think of DIC again like a factory overproducing clot until supplies run out and bleeding everywhere. So that's it um, for the thrombosis and rides. I hope I'm clear here as well. Now, we have discussed, we have mastered the thrombosis, so let's see what happens when a clot or other material breaks off and travels downstream, and this is called as embolism. So embolism are like rogue missiles in the bloodstream, and their effect depends on the size, location, and type. So pulmonary embolism accounts for 95% of the TBT. Classic clinical scenario would be sudden dyspnea, chest pain, and hemoptysis. So huge saddle embolism embolus actually the if I go here, yeah. So huge saddle embolism blocks the pulmonary arteries, and this leads to sudden death. So remember, the classic triad may not be always present together, but more or less this is the clinical scenario: that patient is immobile, or patient is someone the truck driver, and now he is coming to your emergency department with the dyspnea, and he cannot breathe, and he is having high respiratory rate, and that's a very classic scenario of the pulmonary embolism, right? Now there is something called as fat embolism, and keep in mind that that actually happens after a long bone fracture like femur or tibia. Triad of symptoms will include the petechial rash, hypoxemia, shortness of breath, because the fat embolism usually settle down into the lung vessels, and neurological changes, confusion, delirium. The reason is that because patient is not only having the deficient in oxygen, but the emboli might lead to the cerebral vessels, and this can also lead to neurological symptoms, but they are not usually present. Patient also always more or less patient complains of the hypoxemia and petechial rash. Now, another thing that is air embolism, which is caused by the decompression sickness, the nitrogen bubbles form or iatrogenic, like IV line or surgery. Gas bubbles obstruct the vessels, and this leads to the ischemia. Now, the fourth thing is the amniotic fluid embolism occurs during labor or postpartum. Pathophysiology is the includes there are two types of phases. Phase 1 is the pulmonary vasospasm, and the phase 2 is TIC, and it is rapidly fatal if not managed. But please don't worry about it. Please don't worry about the phase 1 and phase 2. I would simply say that remember the amniotic fluid embolism simply as the TIC. What actually happened in the amniotic fluid embolism is that you leak out the tissue factor into the mother's blood circulation, and when the tissue factor is released into the mother blood circulation, it somehow triggers TIC. That's not your that is not something that you should worry about at this moment, but keep the thing in mind that in amniotic fluid embolism, what simply happens is that you somehow leak the tissue factor into the mother circulation, and that triggers a TIC. That's it. So a quick tip for the pulmonary embolism would be that think DVT travels, deep venous thrombosis. The thrombi travels pulmonary artery and obstruct the blood flow and leads to the hypoxemia, and this leads to the sudden onset dyspnea, chest pain, hemoptysis. Severe cases include saddle embolus, and leads to death. Now, if I talk about, there is something called a shock hemodynamics, and I won't go into the detail of every shock here, but I would simply explain you what is the basics of the shock. So shock is basically the systemic hypoperfusion, meaning tissues are not getting enough blood oxygen. So we classify the shock based on the cause, and each type has a unique hemodynamic profile, and it is written over here. So if I simply go up over these, so if the patient is having hypovolemic shocks, if he's not having blood, if the patient is not having blood, the heart is not able to pump the blood out, and there is low cardiac output, of course. Again, if there is no blood in the left atrium, or if there is no blood, if there is no blood in the left atrium, if there is no blood in the left ventricle, if there is no blood in the right, or if there is no blood in the body, so from where you will get the blood in the left atrium or something like that. So that's why PCPW is also decreased. The preload is decreased, right? You're not having enough blood, right? Now the only thing that is increased in the hypovolemic shock is the systemic vascular resistance, because body sense that the patient is having less blood, and somehow you should increase the pressure of the vessel walls, so the body responds by increasing the vasoconstriction of the by vasoconstricting the vessels, by increasing the resistance of the vessels, increase and causing systemic vascular resistance in this, and that is why the SVR is the only increased entity in the hypovolemic shock. Now, if you go through the same concept, then the hypovolemic, cardiogenic, eugenic, and obstructive shock, they are all linked, just like I explained you. So if you go through a similar concept, then you will understand that why the some parameters are high and why some parameters are low in the different types of shocks. So I'm skipping this for now. If there is any difficulty, you can contact me again. But there are something that I would tell you, that there are some skin clues in different type of shock. Skin clues in different type of shock. So in the septic and distributive shock, the skin is warm and flushed because there is reduced systemic vascular resistance. The vessels are vasodilating and they distribute the heat to the body surface, means the skin. And in case of the hypovolemic and cardiogenic shock, the skin is cold, clammy, because the body is having increased systemic vascular resistance, and it is simply tripping off the blood out of the body surface, and the body surface is not, means the skin is not getting enough heat, and that's why skin is cold and clammy. So that's it for the embolism and shock. So yeah, now we're gonna talk about something very high yield, which is neoplasia versus and benign versus malignant. So the ultimate battle of the cells has gone rogue in the world of tumors. So not all tumors are created equal. Some are benign and some are malignant. So benigns are slow, predictable, and they're local, means, whereas the malignant, they are fast, they are destructive, they are deadly. Now there are something that naming traps that, and you should not be fooled by them. Some tumors, they sound benign because of the oma ending, and but are actually malignant. Like seminoma is malignant, melanoma is malignant, lymphoma is malignant, and teratoma, it can be malignant or benign depending on the maturity. So never trust the suffix alone. Always check the behavior. Always. Now there's something called as grade versus stage, and you should know the difference. What's the difference in the grade and what's the difference in the stage? Now, how much the tumor looks like the original tissue. That's actually the grade. G1, it means a well differentiated, right? And G4 is poorly differentiated. It's anaplastic, and it helps predict aggressiveness. The more the worse the grade, or the more the high the grade, the more the worse is aggressiveness, right? And the other thing that is called as stage. So let me revise you again. G1, the less well differentiated tumor simply means that the tumor resembles the tissues, right, and original tissue, whereas the G4 means poorly differentiated, and anaplastic means the tumor does not resemble the original tissue, and it simply means the tumor has grown up into something very wild. Now the other thing it is, which is the stage and extent, the spread. So we use TNM staging for that, T for tumor size, N for nodular involvement, and M for the metastasis. So stage is the most important prognostic factor, keep this in mind. And bigger node, positive metastasize means the worst outcome. Keep in mind that in TNM staging we talk about the tumor size, we talk about the node involvement, and we talk about the metastasis. The node involvement is actually the metastasis at times. So grade is how it looks, and stage is how far it's gone. And stage is the most important prognostic factor. This is a very high MCQ for your stops. Now, for your university exams as well. Now, there's a difference I have given to you between the benign and the malignant tumors. That benign tumors are well differentiated. They look like apparent tissue. Simply, they are, again, I've told you about the grading now. So, and the malignant tumor, they are poorly differentiated. The less you resemble with your parent tissue, the more aggressive you are, the more anaplastic, neoplastic you are. So benign, I have already told you that they are slow, they have low mitotic activity, whereas in malignant tissue they are rapid. They have high mitotic activity. Local benign tissue are circumscribed. They are often encapsulated. They don't grow into the tissues. They are often confined to the space where they are. Whereas the malignant tumor, they are invasive. They invade into the tissue. They are infiltrative. They destroy the surrounding tissues. So in benign tumor there is no metastasis, whereas in malignant tumor metastasis are very common. And in the morphology is the of the benign tumor is that they have no nucleus to cytoplasmic ratio. If the nucleus to cytoplasm ratio is low, then it is a very good thing. But if the patient is having high nucleus, large nucleus, and there is high nucleus to cytoplasm ratio, then it is something called as bad morphology, or you can say some cancerous morphology, some malignant morphology. And you can also see pleomorphism, means different shape of the cells in the malignant tumor. And you can also see the hyperchromatic nuclei, because again the malignant cells are dividing a lot and they have a lot of chromata in the nuclei because they're constantly in the dividing phase. So usually the malignant tumor ends up with the carcinoma, sarcoma types of things, and usually the benign tumor ends up in the oma sort of things. But again, don't trust into the in the don't trust in the suffix only. You should check the behavior of the tumor as well. So I would simply say that benign tumor, they are baby clone of parent tissue, slow and tidy, whereas in malignant tumor they are mutant army, they are fast growing, destructive and spreading. So yeah, that's it. So let's talk about the oncogenesis and tumor suppressors. All right. So we now now that we know benign versus malignant tumors, we should undergo the hood and see what make the cell what makes a cell go rogue. Cancer is basically a genetic problem, you all know, and cells gain growth promoting genes or lose growth suppressing gene in case of cancer. Keep in mind, in the cancer, cell may either gain growth promoting gene. In the cancer, cell may either lose growth suppressing gene. In either cases, the cell is going to divide a lot. So oncogenesis, I would say that oncogenes are simply the gas pedal of the cancer. There is something called as one hit required. Just one allele needs to be this one hit. So in this case, there is only one allele that needs to be mutant to grab the cancer. So so first of all, if I thought there are a few genes that are ROS genes, which is GTPase signal reduction gene, and which is GTPase signal transduction gene, and it is seen in colon cancer, pancreatic carcinoma. There is other gene that is called as MYC gene, MYC, which is gene amplification gene, and it is usually seen in the Burkitt lymphoma. There is other gene, HER2 gene, and this is receptor tyrosine kinase. This gene causes receptor tyrosine kinase amplification, and it is seen in breast carcinoma. And BCR-ABL gene, which is the mechanism of that, it causes fusion protein. It simply causes fusion protein, and there is constitutive tyrosine kinase activation, and it is seen in CML, chronic myeloid leukemia, especially present in the form of Philadelphia chromosome in the 922 location. And now there is something called as BRAF, which is simply a kinase in the MAPK pathway, and it is seen in melanoma, papillary carcinoma. So yeah, that's it. So these are overactive gas pedals, and the cells keep dividing non-stop. Now the tumor suppressor genes, which are the brakes of cancer, the two hits required for them, both allele must be inactivated. You have to think it as tumor suppressors are the brakes. If they fail, the car cell crashes into uncontrolled growth. So and the two hits required, again, I simply means that you need both of the allele to be mutated or inactivated in order to cause cancer. So the first one is TP53. This is a guardian of genome and DNA damage checkpoint. And the cancer example would be the Leaf-Remini syndrome, multiple malignancies. The other one is retinoblastoma RB gene. It regulates T1 and S points, and it causes retinoblastoma and osteosarcoma. The other gene is BRCA1 and BRCA2, or BRCA1 or BRCA2. The function of these genes is to DNA repair, and the example would be breast and ovarian carcinoma. And the other gene is APC. It simply causes colorectal tumor suppression, and the example would be the FAP, familial adenomatous polyposis, and which ultimately leads into the colorectal cancer. And the other one is VHL1 Hippolyndus disease and Williams tumor 1 gene, and VHL it's simply responsible for the hypoxia signaling, and WT1 gene, Wilms tumor 1 gene, it is responsible for the kidney development. And the example of these genes would be the VHL gene leads to renal cell carcinoma, clear cell renal carcinoma, and the Wilms tumor 1 gene leads to simply in the Wilms tumor. So 2 hits stop the cell. Both allele must be lost for tumor suppressor inactivation. So now moving on towards the next topic, which is the carcinogenesis and paraneoplastic syndromes. So we have covered the tumor biology. Let's look at what triggers cancer and how tumors can cause remote effect. And there are two exam favorites. So think of carcinogens as a spark that ignite the tumor engine, and paraneoplastic syndrome as the remote alarm that the tumor sets off in other organs. So let's talk about the chemical carcinogens. So certain chemicals in the environment or the workplace can mutate DNA and initiate cancer. So the first one is the aflatoxin, and the source of aflatoxin B1 is the aspergillus in the stored grains, which is a type of fungi, and it leads to the hepatocellular carcinoma. The other one is nitrosamine, and it is in the smoked foods, and it can lead to the gastric carcinoma. The other one is asbestos. It is present in construction and roofing, and can lead to lung carcinoma and mesothelioma. And the other thing is benzene, that is present in the paint and solvent, and that might lead to the AML and leukemia. The other one is the vinyl chloride. It is present in the PVC pipe, and that leads to the angiosarcoma of the liver. Now, there are something called as oncogenic microbes. They are hidden hijackers, and some viruses and bacteria can also trigger tumor. The HPV 16 and 18, it can cause the HPV 16 and 18, it can cause the cervical, anal, and oropharyngeal carcinoma. The EBV, Epstein-Barr virus, can simply cause the Burkitt lymphoma and nasopharyngeal carcinoma and Hodgkin lymphoma. And the HBV, hepatitis B virus, and hepatitis C virus can simply cause the it can simply cause hepatocellular carcinoma, and the Aspergillus can simply cause the gastric adenocarcinoma and Malt lymphoma. So viruses often insert oncogenes or inactivate tumor suppressor gene, while bacteria causes chronic inflammation, and that leads to the cancer. Actually, both of the things can lead to the cancer. Okay. So now, if we talk about the paraneoplastic syndrome, so they are remote effects of the tumors, and often due to hormone or cytokine production. In case of small lung cancer, patients usually have something called as SIADH, in which there is a lot of secretion of ADH, and there is hyponatremia due to a lot of fluid in the body, and that leads to confusion and seizures. Now, there is something called as Cushing syndrome, and it can also appear as a part, which can also be a part of the paraneoplastic syndrome if the paraneoplastic syndrome involves the increased ACTH release, and this leads to the hypertension, the weight gain, and the moon face. Now, Lambert-Eaton myasthenia gravis syndrome, in which there is VGCC antibodies, and there is proximal muscle weakness. So anti-VGCC antibody simply means anti-voltage gated calcium channels antibodies, and when these antibodies are destroyed, then the neuron cannot simply promote the action potential perfectly to the next neuron, and that leads to proximal muscle weakness, Lambert-Eaton syndrome. So the other tumors, other tumors means hypercalcemia. Other things that can also that you can also see in the other paraneoplastic syndrome, you can see in the other tumors like hypercalcemia due to increased release of parathyroid related peptide that is usually seen in the squamous cell carcinoma, or renal cell carcinoma, or breast cancer, and the labs often show less PTH and increased calcium because there is increased release of parathyroid-related protein, not actually the parathyroid. Acanthosis nigricans, which is seen in the gastric adenocarcinoma, velvety and hyperpigmented skin is seen. Polycythemia, in which there is increased release of EPO, and it is seen in the renal cell carcinoma, hepatocellular carcinoma, hemiangioblastoma, and the lab shows increased hematocrit volume. Now, this is not the last thing. I'm left with a few more slides, and I'm sorry for extending this discussion a lot, but again, these are some important things that I need to discuss with you. Now, we have discussed the tumors and paraneoplastic syndrome, and let's switch the gears now to the protein misfolding disorder, specifically amyloidosis. So think of amyloidosis as a sticky misfolded protein that pile up outside the cell, cause tissue damage by pressure atrophy. So what is actually amyloid is? It is an extracellular deposit of beta pleated sheet proteins, right? And the mechanism of damage is simply crowding and disrupting the normal tissue architecture. Think like packing too many boxes into a room and eventually furniture and the walls get squished. So diagnosis is done by the Congo red stain. Amyloid appears salmon pink under normal light and apple green birefringence under the polarized light. And diagnostic, this is the diagnostic hallmark. Exam tip would be Congo red apple green birefringence. Now, organ involvement for the amyloidosis is that at heart, if there is a lot of protein deposited around the heart, then it will lead to the restrictive cardiomyopathy, diastolic dysfunction. If there is a lot of protein deposited around the kidney, then it will lead to the nephrotic syndrome, proteinuria, and edema. If there is a lot of protein deposited around the tongue, then it will lead to the macroglossia, enlarged tongue. And if there is a lot of protein deposited along the nerves, especially the median nerve, then it will lead to the carpal tunnel syndrome, which is due to median nerve compression. Now, there are different types of amyloid protein, and the first one is AL, which is caused by the primary AL amyloidosis, which is also called as primary amyloidosis, in which the IgG light chains simply deposits around in which the IgG light chains deposit around the organs, and this actually happens in conditions which are producing a lot of antibodies, specifically in the multiple myeloma. And the next thing is the AA secondary amyloidosis, which actually happens in the state of chronic inflammation, like rheumatoid arthritis or TB. And now there is something called this ATTR, and it actually happened due to transthyretin, in which there is a lot of transthyretin in the body, and it actually happens in the people who are adult, and when the people are adult, there is a lot of transthyretin protein in the body, and that actually deposits around the heart, and that leads to senile cardiac amyloidosis. There is something called as a beta amyloidosis, in which there is beta precursor protein, and that is actually seen in the Alzheimer's disease. And there is something called as beta 2 microglobulin protein, and this is MHC class 1 component, and it is seen in the dialysis related amyloidosis. Keep this in mind, that in dialysis people, you cannot remove the beta 2 microglobulin protein easily. The beta 2 microglobulin protein is easily removed by the kidneys in a normal patient, but in dialysis patient you cannot remove this protein, as a result of which this protein piles up and builds up, and this leads to the amyloidosis, and it's of course if the protein is depositing around the tissues. Now, there is something called as amyelin related amyloidosis, and this is due to a protein called as amyelin, and this is seen in patients with type 2 diabetes mellitus, and it is something very, very rare, so I don't think so it is something that you will experience at the exam, but keep in mind that type 2 diabetes mellitus is related with amyelin related amyloidosis. So, now our discussion would be about the inclusion bodies, then some exam buzzwords, and then we are done, right? So let's talk about some viral inclusion bodies. So we have covered the systemic pathology. So now we have to zoom into the cellular pathology, specifically the inclusion bodies. So think of inclusion bodies as a crime scene markers inside a cell, and they tell you what happened and what pathogen or disease is at work. So Negri bodies, which is seen in the rabies virus. Let's move on to this. It is seen the rabies virus and the appearance is that eosinophilic cytoplasmic inclusion in neurons, specifically in the Purkinje cells and hippocampus, and the high yield tip exam tip would be rabid dog hits the cerebellum and the hippocampus. So now other inclusion body is the Cowdrey A, and yeah, it is the Cowdrey A, and it is seen in the viruses like the HSV and VZV and herpes simplex virus and varicella zoster virus, and the appearance is eosinophilic intranuclear inclusion, and the high yield examination tip would be herpes simplex and varicella zoster virus. They are classic exam habits. So the next thing is the owl's eye appearance, which is seen in cytomegalovirus, and there are large intranuclear inclusion with clear halo, and it can also be cytoplasmic. And think like cytomegalovirus is chronic in the chronic immunosuppressed patient, right? Because it is again opportunistic infection. So yeah, now, if I talk about the non-viral pathology, because the Negri bodies, the Cowdrey A, the Owl's eye, they all are the you can say that they are all viral related pathologies, right? Now, if I talk about the other type of pathologies, the non-viral pathologies, so I'll discuss about the so I'll discuss about the first of all, let's talk about the Mallory bodies, and they are seen in alcoholic hepatitis patient, and the appearance would be eosinophilic cytoplasmic clumps of damaged cytokeratin in the hepatocytes, and the Ascough bodies, they are seen in rheumatic fever, and the appearance would be granulomas in the myocardium, giant cells, and antisco cells, also called as caterpillar nuclei. The Lewy bodies, which are seen in Parkinson's disease, they are round eosinophilic cytoplasmic inclusion bodies of asynuclein protein in the substantia nigra. And the other thing is the pig bodies, because they are which is seen in pig disease, which are spherical aggregates of the hyperphosphorylated tau protein in the frontal or and temporal lobe of the brain, specifically in the frontotemporal dementia. Now, there is something which is bonus for you, is that there is something called, which is not a part of our discussion at this stage, but I'll tell you that there is something called as Heinz body, and they are simply precipitated hemoglobin, which is seen in G6PD deficiency, right? And they appear as in exams at bite cells after oxidative stress. So other thing is the Howell Jolly bodies, and they are nuclear remnant, and they are seen in asplenic patient, because the spleen simply removes the Howell Jolly bodies. But if the patient is asplenia due to some reasons, so the patient cannot remove these bodies, and they appear in RBCs as a nuclear remnant. So now our last topic is about the buzzword, and I'll simply summarize the stuff. And this slide will let you instantly recognize a diagnosis from a single phrase, and this is the most important, not the most important I would say, but it's a very helpful part of the lecture. So apple green birefringence, amyloidosis; coast cell outlines, cognitive necrosis; DNA laddering, apoptosis; Cheezer necrosis, caseous necrosis; lines of Zahn, arterial thrombosis. And my question is, what you give to treat the arterial thrombosis? Aspirin or heparin? Aspirin. Saddle embolism, pulmonary embolism; nutmeg liver, chronic passive congestion. And I think I have not told you what is nutmeg liver is, but I'll tell you in some other lecture. Some bodies, papillary thyroid cancers, and meningiomas, and carcinomas. Philadelphia chromosomes is linked with chronic myeloid leukemia. Councilman buddies is related with the viral hepatitis. Cholextra buddies is related with the granulosa cell tumor. Oval eye nuclei, Reed-Steinberg cell. It is seen in the I'm not talking about the oval inclusion buddies. I'm talking about the oval eye nuclei. Oval eye nuclei is seen in the Hodgkin lymphoma. Keep this in mind. Orphan nuclei is seen in the papillary thread cancer. And keratin pearls, they're seen in the squamous cell carcinoma, and the signet cell ring cells, they're seen in gastric adenocarcinoma. So that's it from my side, and we're done with the high yield pathology lectures. This should be your schedule when you are studying for the step 1, and for the for your, you can say, your basics pathology, right? But I think that I've covered everything in this lecture, and there I'm left off with a few things, so you can contact me and ask those stuff. And yeah, you have got this. So what I actually, there's something that I want to tell to my students, specifically those who are in touch with me in my university. You guys can reach me out anytime. I would love to help you guys, because what I think that when you are senior, and when you know a bit more stuff than the other, so you should always be humble, and you should always uh, give your hand for help. So I'm always available of any kind of help that I can give you guys. Uh, my juniors, everyone, my colleagues means a lot to me, and I would literally love to help. So you can contact me anytime on my WhatsApp, on my Instagram, on the Instagram page of 2FOP. Ritik and I will love to help you out, because we both are very, the reason why we created this platform, this forum, is just to help the students, just to help the candidates, the help which we were in need back in when you were preparing for this stuff. So I'll remember you guys in my prayers. Keep me in your prayers. That's what I want from you. And thank you so much for listening to me for 2 hours. Thank you so much. Take care.